Hello folks, welcome everyone. I'm Dr. Patil and here we will be taking you through the previous year important MCQs for the upcoming NEET PG exam, and I think all of us agree, all of us are very much familiar that previous year questions and the topics based on which these previous year questions were designed cover around 30% of the questions that will be asked in any of the exams, right? So that's why it is important for us to understand the previous year questions. So our focus will be quickly getting to the previous year questions and understanding a little bit here and there towards the topic, because merely knowing the question is not enough. Some extra points we need to know, right? So let me start with the first question for today. This is the first question for the day. The question goes like this: we have a woman in her early 40s and she is taking analgesics regularly for headaches for past 6 months. The intensity of the headache in severity increased in last 3 days and reduced when she stopped taking the analgesic. What is the likely diagnosis? First, before I address this question, right, let me ask you some basic questions. Analgesics, are they drug of choice for any of the following type of headaches for acute treatment? Well, for tension type of headache, yes, we use NSAIDs as the drug of choice. Absolutely agree. Okay. Then for patient with chronic migraine, we do consider NSAIDs, the strong NSAIDs as the initial treatment of choice, but in most patients with migraine it is not helpful, and that is why the drug of choice for migraine is triptans, right? And when it comes to cluster headache, the drug of choice is oxygen. So let me write it down because those are important points. The drug of choice for cluster headache is oxygen. The drug of choice for tension type of headache is NSAIDs when it comes to acute treatment. And okay, let me again write it down. We are talking about acute treatment. I don't want any of you to get confused between acute treatment and preventive treatment. Okay, and then the drug of choice for chronic migraine is triptans. Okay, and we should be familiar that there is an entity called as medication overuse headache, where if a patient having chronic headaches goes on taking NSAIDs, eventually the headache stops responding, and merely because of the abuse of medications, the headache intensity goes on increasing. And that should be one of our differential diagnosis for any patient with chronic headache who comes and says that my headache intensity is increasing in the recent days. And in such case, what should I do? How do I confirm that this is medication overuse headache? Simple. All I need to do is stop the patient from taking the NSAIDs for few days, and the result will be in front of you. If the headaches improve after patients stop taking NSAIDs, then it is medication overuse headache. And this story is typical of the medication overuse headache, and that is why option D will be our answer for this question. So for this question, our answer is medication overuse headache. Okay. Now let me take you through the next question for the day. This is question number 2. A known case of mitral stenosis. Okay. Now before I talk more about the condition, let me ask you, what is the most common cause for mitral stenosis? What is the most common cause for mitral stenosis? Remember, the most common cause for mitral stenosis is rheumatic heart disease. This is something that I always want you to remember. For all practical purposes, a patient with mitral stenosis in India will be believed to be of rheumatic in origin until and unless proved otherwise. All other causes that you study in books are extremely rare, and they may be contributing for less than 1% of all cases of mitral stenosis, and that is why whenever you see a patient with MS, think of rheumatic heart disease. During my days, when I used to answer saying that, sir, this is the second most common cause, third most common cause, our examiners used to kick us out from the exam hall because they wanted to hear only rheumatic heart disease. Okay, good. Now, the patient presented with breathlessness and chest pain in her early 20s. On examination, the pulse was irregular, and we could find a thrombus on echocardiography. No thrombus was found on echocardiography. Okay, cool. Now the pulse was irregular. What does that mean? Pulse is irregular. It suggests that patient is having atrial fibrillation. And whenever we have atrial fibrillation, atria is not contracting, it is merely vibrating, shaking or fibrillating. And because of that, some part of the left atria, the blood may not be moving it provides stagnation, and as we know from Virchow's triad, stagnation or stasis is one of the risk factors for formation of clot, and that is why atrial fibrillation becomes a reason for someone to develop clot. Well, now in patient with atrial fibrillation, if there is a clot, definitely it warrants anticoagulation, because otherwise there is a risk of that clot coming to left ventricle, to aorta, aorta to internal carotid, from carotid to middle cerebral artery, and most likely an MCA stroke. So atrial fibrillation, as we know, is associated with increased risk of stroke. There is increased risk of stroke if an individual has atrial fibrillation. How do I mitigate this risk? By considering anticoagulation. But when I have to consider anticoagulation, I have to also value the risk of bleeding that anticoagulation can bring in. So it is not a blanket treatment like every patient who has atrial fibrillation we should be giving anticoagulants. No. Now we follow a criteria called as CHA2 DS2 VASC score to decide about for which patient we need anticoagulants, in which patients aspirin alone would be adequate, right? Okay. So remember this point. Decision about anticoagulation is based on CHA2 DS2 VASC score. CHA2 DS2 VASC score. All these scores are important, and I will be doing a separate session for scores just before your exam, so that you can brush up your memory of scores, and generally 2 questions come from scores, so you will be able to sail through those questions. Okay, but there are certain conditions which are exceptions, means in those disorders you don't need to look at CHA2 DS2 VASC score. If you have atrial fibrillation plus this entity, go ahead and anticoagulate directly without looking at the CHA2 DS2 VASC score, right? So we should in fact start anticoagulation directly without looking at CHA2 DS2 VASC if atrial fibrillation occurs in patients with number one, most important one, right, that is rheumatic heart disease, right? Rheumatic heart disease, I would specifically call it as rheumatic valvular disease. Rheumatic valvular heart disease. And there is a second entity where again guidelines recommend that you don't need to look at the CHA2 DS2 VASC score, directly start anticoagulation, which is hypertrophic cardiomyopathy. And there is a third entity I want you to remember, which is nothing but previous stroke or TIA. So if any of these 3 are present, you don't need to look at the CHA2 DS2 VASC score. For this previous stroke, anyway, even if you apply CHA2 DS2 VASC score, when there is previous stroke or TIA, patient gets 2 points and definitely becomes eligible for anticoagulation. I want you to remember these 2. If a patient is having rheumatic heart disease and that has led to mitral stenosis and thus atrial fibrillation, or patient is having hypertrophic cardiomyopathy, in both these cases the risk of embolization is extremely high, and we shouldn't be looking at CHA2 DS2 VASC score to decide whether to give anticoagulants or aspirin alone. They require anticoagulation, right? They require anticoagulation, a very, very important point. So now this patient is definitely, or it will be presumed to have rheumatic heart disease, right? So rheumatic valvular heart disease leading to atrial fibrillation demands anticoagulation. Now obviously then in that case, aspirin alone is not enough. Aspirin plus clopidogrel not enough. I have to choose anticoagulants, and there are 2 options here, dabigatran and warfarin. Which one we should choose? That's the question. Generally, direct acting oral anticoagulants are considered superior to warfarin because they have a predictable response. Warfarin doesn't have a predictable response, right? Warfarin requires the dose titration with INR, which is not required for direct acting oral anticoagulants. But because their safety and efficacy is not studied in patients with rheumatic valvular heart diseases, still now it is warfarin which continues to be the drug of choice when it comes to anticoagulation in RHD. So I want you to remember this point, that the answer here will be oral warfarin. It is the drug of choice for anticoagulation in RHD and in patients with metallic prosthetic valves. Metallic prosthetic valves. For everything else, you can consider dabigatran. If there is a patient with atrial fibrillation and he has hypertrophic cardiomyopathy, I don't need warfarin. I can directly start with the dabigatran, zimilgatran, apixaban, right? I can start with them. Or there is another patient who has hypertension and developed chronic AF. I don't need to use warfarin. I can definitely go ahead with a direct acting oral anticoagulant. So only under two circumstances we use warfarin. The first one is rheumatic heart disease and the second one is patients with metallic prosthetic valves. Again, I am emphasizing my word metallic prosthetic valves. I am not saying bioprosthetic valves. There are two types of prosthetic valves. Like for example, there is a patient with stenotic valve or a regurgitant valve and I replace it. My replacement can be either with a metallic valve or a bioprosthetic valve. If I am using bioprosthetic valve, I can still go ahead with the direct acting oral anticoagulants. But if I am using a metallic prosthetic valve, then I have to stick to warfarin, because in these two cases, RHD and metallic prosthetic valves, we don't have sufficient data to say that the direct acting oral anticoagulants are as safe as warfarin or as good as warfarin. In future, we may start using direct acting oral anticoagulants for these patients as well. Okay. Now this is an important point, guys. This has been asked in the previous year NEET PG. In which of the following conditions we can directly start anticoagulation without basing our decision on the CHA2 DS2 VASC score in a patient with atrial fibrillation? Rheumatic heart disease, hypertrophic cardiomyopathy and previous stroke or TIA. Okay. Now the next question. A patient presenting with mid-diastolic murmur and JVP showing prominent A waves. So patient has an MDM and JVP showing a prominent A waves. What is the most likely diagnosis? So I will give you an idea how we should approach a patient with valvular heart disease. First thing you have to see is whether the symptoms or signs are suggestive of a right heart dysfunction or they are suggestive of left heart dysfunction. So if there is a problem with the left heart, the pressure in the left atria will rise and patient will develop congestion of the lungs. That will lead to dyspnea, orthopnea, PND as the predominant symptoms. If the patient has a dysfunction of the right heart, in that case, the pressure in the right atrium will rise. That will lead to, number one, rise in the JVP. Number two, because the flow of blood from liver to inferior vena cava will be impaired, there will be congestion of the liver. So whenever patients' findings are suggestive of raised JVP and congestive hepatomegaly, think of right heart dysfunction. Whenever patient is complaining of dyspnea, orthopnea, PND, think of left heart dysfunction. So now they are already telling that JVP is showing prominent A waves. That means it is a pathology which is affecting right side of the heart, less likely a pathology affecting the left side of the heart. So quickly and easily you can rule out the left heart pathologies. It can't be mitral stenosis because mitral valve is between my left atrium and left ventricle. So that is ruled out. Similarly, mitral regurgitation is ruled out. I am only left with tricuspid stenosis and tricuspid regurgitation. Now if I know the murmurs, my answer is done. So please remember, the tricuspid stenosis generally causes a pan-systolic murmur. It causes a pan-systolic murmur. And the tricuspid stenosis causes the mid-diastolic murmur. It causes the mid-diastolic murmur. Now you may be asking, sir, why does it cause mid-diastolic murmur? The answer is pretty simple. When do we transfer blood from atria to ventricle? During systole or diastole? We transfer during the ventricular diastole. During diastole, ventricle receives the blood. During systole, it ejects the blood. So if my valve does not open properly, the tricuspid valve, that is what we call as stenosis, will it affect the left ventricular diastole or will it affect the systole? The transfer of blood from atria to ventricle happens during diastole. That is where this valve is supposed to be open. It is not properly open. So an improperly open narrow opening creates the turbulence to the flow of blood, and that is what we hear as murmur. That's why it is a diastolic murmur. If I have tricuspid regurgitation, what does that mean? This tricuspid valve is supposed to be shut during the ventricular systole, so that ventricle ejects the blood into the pulmonary artery. To prevent regurgitation of blood from ventricle to atria, it should be shut. But unfortunately, if it fails to shut, then blood will start moving back from ventricle to atria. When this is happening? See, during diastole, we transfer to ventricle. During systole, when ventricle contracts, blood will leak back. So when is it happening? It is happening in systole. That is why tricuspid regurgitation causes a systolic murmur. Okay. And I will tell you one more rule for you to remember. How many valves we have? 4 valves. Each valve has 2 conditions, a stenosis and a regurgitation. But we don't need to study so much in detail. All you need to know is pick up one-sided valves. Like for example, between right atrium and right ventricle, which valve I have? Tricuspid valve. What is its counterpart on the left side? Between left atrium and the left ventricle, I have the mitral valve, right? Both of them will have similar murmurs. What does that mean? If I have tricuspid stenosis, if I am having mid-diastolic murmur, for mitral stenosis also I will be having mid-diastolic murmur. And similarly, if I am having pansystolic murmur for tricuspid regurgitation, I will have pansystolic murmur for mitral regurgitation. We'll have pansystolic murmur for the mitral regurgitation as well. So it is pretty simple. As long as you know that each valve has a counterpart on the opposite side and you know murmur from one valvular lesion, you will also be able to extrapolate it to the other valvular lesion. For example, between my aorta and left ventricle, I have the aortic valve, right? Aortic stenosis produces ejection systolic murmur. We call it as ejection systolic murmur. Similarly, I have pulmonic valve between my right ventricle and pulmonary artery. So if I have pulmonic stenosis, it will also produce ejection systolic murmur. Aortic regurgitation produces early diastolic murmur. So if I have pulmonic regurgitation, that will also produce early diastolic murmur. Okay, clear? Himanshu Chaudhary, no, those are 2 different things. Pulmonary capillary wedge pressure indirectly talks to you about the pressure in the pulmonary veins. Okay, I'll tell you. This is my left atrium, right? And as we know, the blood to left atrium comes from pulmonary veins. 4 of them are there. For simplicity, I will write only 2. From where the blood comes to these pulmonary veins? From the lungs. So here I have the lungs. So lungs receive the blood from pulmonary artery, and then this blood returns to left side of the heart through pulmonary veins. So pulmonary capillary wedge pressure is where we pass a catheter to go into the pulmonary artery, go into the pulmonary capillaries and get stuck there, and then we will measure the pressure there, which indirectly tells you how much pressure is there in the pulmonary veins. Pressure in the pulmonary artery can be directly measured by putting the catheter. That is what we call as pulmonary artery pressure. Pulmonary capillary wedge pressure is an indirect measure for the pulmonary venous pressure. Okay. So that's about this question. This question is pretty straightforward, right? It says that we are talking about a right heart pathology because the JVP is raised. It is showing prominent A waves. Why do we get prominent A waves in tricuspid stenosis? Because the right atrium, A wave is produced by the right atrial contraction. When it contracts, if the valve opening is narrow, it builds up a lot of pressure inside the atrium. That pressure will reflect onto your JVP. That's why we get prominent A waves. So answer for this question is flat out simple, that is tricuspid stenosis. I will give you the conditions where you get prominent A waves. Prominent A waves on the JVP can be seen in first one, yes, tricuspid stenosis. Tricuspid stenosis. Second one, when you have right ventricular hypertrophy. Third one, when you have pulmonic stenosis. In these cases, you get prominent A waves. And then there is also something called as Cannon A waves. Can anybody tell me where do you get Canon A waves on the JVP? Canon A waves. Gautam Fulara, yes, these are only the NEET PG PYQs. These are mainly last three years, only the last 3 years. Canon A waves we get when we have what is called as AV dissociation. Now what is AV dissociation? AV dissociation refers to divorce between atria and ventricle. Normally what happens when atria contracts? When this atria is contracting, ventricle will be relaxing so that it receives the blood. If both of them start contracting simultaneously, means they are now divorced. There is no relationship, right? There is a give and take relationship. Atria gives, ventricle takes. So atria is in systole, ventricle will be in diastole. Only then atria can give, ventricle can take. But if you divorce them, then this give and take relationship is gone. Both of them are trying to give or both of them are trying to receive simultaneously. Such condition is what we call as AV dissociation. It can happen in 2 circumstances. The first one is when you get atrioventricular blocks, AV blocks, and the second one is when you get ventricular tachycardia or ventricular fibrillation. That is where you can get giant A waves or Canon A waves. Okay. Now coming to our next question. A chronic alcoholic patient presented with abdominal distension, swelling of the legs and reduced urine output. Serum creatinine is 1.6 milligrams per deciliter. What is the next line of management? So just tell me what do you think is the diagnosis here. This is a simple straight out question. Nowadays NEET PG clinically oriented questions are not very tough or difficult. They are little straightforward. So what do you think is the diagnosis here? History says that patient is chronic alcoholic, right? That is the first clue. He is a chronic alcoholic. He presented with abdominal distension, swelling of the legs. So this tells me that he has already developed a decompensated cirrhosis of liver, right? So my first diagnosis here is decompensated cirrhosis of liver. He has developed significant ascites. Okay, and after that he has developed one of the complications of chronic liver disease, which is hepatorenal syndrome. Why should his urine output decrease and why his creatinine should raise? It is because he has developed a well-known complication of chronic liver disease, which we call as hepatorenal syndrome. Hepatorenal syndrome. Why that happens? Because once you have chronic liver disease, there is splanchnic vasodilatation. What does that mean? The blood going to your gut and the spleen, there is vasodilatation. So more and more blood goes into that circulation and less blood goes to kidney. And if kidneys are not getting blood supply, they start losing their function. That is how the creatinine starts going up, urine output starts coming down. Now, if I have to treat this patient's problem, what should I do? Can I help him by giving methylprednisolone? In which disorder we use steroids? Which liver disorder we use steroids? There is only one liver disorder where we use steroids. The drug of choice is steroids. So what am I talking about? Yeah, 2, agree. Okay, 2. So it may be useful, or in fact it is a drug of choice for what we call as alcoholic hepatitis. Now please don't get confused between alcoholic hepatitis and decompensated cirrhosis of liver. Alcoholic hepatitis is an acute liver disorder. It is a acute liver disorder. It is not a chronic disorder. So in this case, it's a chronic disorder. He has already developed ascites, swelling of the legs. So it's a chronic disorder. Acute liver dysfunction because of binge drinking or heavy consumption of alcohol, we call it as alcoholic hepatitis. For that treatment, we can use methylprednisolone. Second, we can be used for patients with what we call as autoimmune hepatitis. Autoimmune hepatitis. Okay. Now my question is, should I give heparin for this patient? Absolutely no. Please remember, whenever you have chronic liver disorder, there will be reduced production of factor 2, 7, 9, 10 because of vitamin K deficiency. Chronic liver dysfunction leads to vitamin K deficiency, and that can lead to the deficiency of factor 2, 7, 9, 10. That is why often patients with liver disorder have tendency to bleed. right? So giving heparin for them can be life threatening, so we should avoid it. Okay. Now if I give diuretics, will it help this patient? Diuretics are an important precipitating factors for hepatorenal syndrome. Why hepatorenal syndrome is happening? Because there is splanchnic vasodilatation, and also ascites increases the intra-abdominal pressure, compresses the renal vessels, reduced blood supply to kidneys. If I give diuretics, we lose fluid. By losing fluid, we are reducing the circulating blood volume, and again less blood will come to kidney. So it will worsen, right? We should avoid it. So whenever you have a patient with hepatorenal syndrome, right, we should be in fact avoiding it. Avoid in hepatorenal syndrome patients. And what is the drug of choice? Yes, the drug of choice for hepatorenal syndrome is octreotide along with albumin. Now why this is a drug of choice? So by giving albumin, we will be able to tamper with the oncotic pressure and reduce the edema as well as ascites. And by giving octreotide, octreotide is a potent vasoconstrictor and it has profound effect on the splanchnic circulation. So because of that, we will constrict the splanchnic blood vessels, whatever blood that is pooled in the splenic artery and the mesenteric veins, all of that will be coming back to the circulation and thus it will be reaching the kidneys. So that is why we use yes, see, whenever we have mitral stenosis, the mitral valve has become narrow, so pressure in the right atrium starts going up. So once the pressure in the right atrium starts going up, the pressure in the pulmonary veins will start going up, and once the pressure in the pulmonary veins starts going up, eventually pressure in the pulmonary capillaries will start going up. That will subsequently lead to rise in the pressure in pulmonary arteries. See, basically blood comes from pulmonary artery, passes through the capillaries to go to pulmonary veins. So if pressure in the pulmonary vein is high, it will become high on the capillaries, it will eventually become high on the pulmonary arteries. So that's why we make a statement saying that the most common cause for right heart dysfunction is left heart dysfunction. You talk about any left heart disorder, eventually it will lead to pulmonary hypertension. That's why we say most common cause for right heart failure is left heart failure. Okay. So octreotide is the drug of choice for hepatorenal syndrome. Why is it so? Because octreotide causes splanchnic vasoconstriction, causes splanchnic vasoconstriction. And nowadays, please remember, we have replaced octreotide with another drug called as terlipressin, which is more selective in causing splanchnic vasoconstriction than octreotide. So make a note somewhere there, because if you get both options, I want you to choose terlipressin. Terlipressin is preferred over octreotide. Is preferred over octreotide. Preferred over octreotide because of its higher selectivity for splanchnic vasoconstriction. Okay. Now let me take you through the next question. Joy, right, autoimmune hepatitis also we use steroids. Okay. Along with that, we often need immunomodulators also in autoimmune hepatitis because the recurrence risk is high. Okay. So now in this question, we have a 72-year-old man who was brought in with the complaints of cough with yellowish sputum. On examination, respiratory rate is 20 per minute, BP is 110/70, he is not confused and he is hemodynamically stable. Lab report showed urea levels of 44 milligrams per deciliter. What is the next best step in the management of this patient? So what are we talking about? What is the diagnosis here? A person has presented with cough, right? And look at the description of the sputum. Cough with yellowish sputum. That means patient has got an respiratory infection, right? So we will consider it as a community acquired pneumonia. Community acquired pneumonia or CAP. And whenever we have a patient with community acquired pneumonia, the decision whether I should treat them as an outpatient or treat them as an inpatient, and if they are going to inpatient, whether they should go to the wards or ICU will be based on a tool called as 𝐒𝐄𝐝65. Absolutely right. Yes, the most common cause for pneumonia is Streptococcus pneumonia. So the decision about admission versus OP treatment is based on what we call as 𝐒𝐝 65. Okay, can anybody tell me other better scores other than 𝐒𝐝 65? There is a score which is actually recommended, which is superior to 𝐒𝐝 65, but it is not practical for us to use because it is cumbersome. 𝐒𝐝 65 being simple continues to rule our practice, but there is another tool which is more effective, more reliable with respect to predicting the mortality. What is that score called as? Another score is called as PSI, not police sub inspector, it stands for Pneumonia Severity Index. Pneumonia Severity Index. This is the preferred tool, but we will never get questions on it because it is a complex tool, difficult to remember even as a doctor. I also don't remember. All I do is, there are calculators available online like mdcalc.com. I put patient's data there and I will get the score and I will make a decision based on that score. But 𝐒𝐝 65 in itself is a mnemonic and easy to remember. That is why examiners continue to ask questions on it. Every alternate exam, there will be one question on the 𝐒𝐝 65. Just like ABCD2 score for TIA risk of stroke, CHA2 DS2 VASC score for deciding anticoagulation versus aspirin alone or aspirin plus anticoagulation in a patient with atrial fibrillation. Similarly, 𝐒𝐝 65 is an important scoring. As I told you, 𝐒𝐝 65 itself is a mnemonic, so we don't need to put any extra effort. So see here in 𝐒𝐝 65 stands for confusion, U stands for urea, to be more precise it is the blood urea nitrogen, it's the blood urea nitrogen. Then R stands for respiratory rate and S stands for, the B stands for the systolic BP, and then 65 stands for the age. Okay. So if patient is confused at the time of presentation, we will give 1 point to patient. If patient's BUN is more than 19 milligrams per deciliter, we will give 1 point to patient. If patient's respiratory rate is more than 30 per minute, we will give 1 point. And if the systolic BP is less than 90 or diastolic less than 60, we will give 1 point. If the age of the individual is more than 65, we will get 1 point. So let us see how much points we can give for this patient. What is the age of the person? Age is 72 years. So we got 1 point there. Okay. Then they have not mentioned he is confused anywhere. So I am not giving C score for him, right? Okay. What about the urea levels? Urea levels are definitely increased. Urea levels are increased. So I will give 1 point for the patient. Okay. Respiratory rate is not more than 30, so he will not get any point here. Okay. And his BP appears to be fine, neither diastolic or systolic demand a point, right? So there is no confusion either. So patient is going to get 2 points here, one for age and one for his blood urea levels. Okay. So now applying the 𝐒𝐝 65, the recommendation is if the patient has 2 points, he should be hospitalized preferably, and if it is more than or equal to 3 points, he should be hospitalized preferably in ICU, right? Okay, so 2 or more than 2, we go for admission, and 0 or 1, it is the outpatient management. You will get different takes on this score in different books. Don't get confused. Simple thing is 0 to 1, outpatient treatment, right? More than or equal to 2, inpatient treatment. Okay. And if it is more than 3, we have to consider ICU. More than 3, we have to consider ICU. And because this patient is getting 2 points, he should be admitted. But definitely he does not require the admission in the ICU. So B makes the sensible right choice here. Give antibiotics and send the patient home would have been logical if 0 to 1 points, right? Admit to ICU with invasive mechanical ventilation. See, please remember the decision about invasive or non-invasive ventilation is not based on the 𝐒𝐝 65. 𝐒𝐝 65 will only help us to decide whether outpatient or inpatient, and if inpatient, ICU or ward. The decision about mechanical ventilation is based on the ABG, patient respiratory rate. Okay. So the answer B would be correct here. So please spend some time on remembering the 𝐒𝐝 65 score. Now here is our next question. We have a 29-year-old man who complained of excessive fatigue by the end of the day. I think this is a pretty simple, straightforward question. Excessive fatigue by the end of the day that improved with rest. There is history of ptosis, difficulty in speech, and swallowing was also mentioned. What is the most likely diagnosis? See, weakness as a complaint can happen when you have disorders affecting the muscle, disorders affecting neuromuscular junction, disorders affecting the peripheral nerves, disorders affecting the spinal cord, disorders affecting the brainstem, disorders affecting the cortex and subcortex of the brain. All of them can cause weakness of muscles. It is a pattern that gives out the clue, right? So here they have mentioned one important thing, which is excessive fatigue by the end of the day. What does that mean? The patient's weakness have diurnal variation. There is diurnal variation. Diurnal variation is the hallmark of neuromuscular junction disorders. If I cut somebody's spinal cord, I won't see him walking in the morning and getting tired in the evening. If I cut somebody's peripheral nerves, I won't see him doing the normal activities in the morning and then losing the functions in the evening. If I develop a stroke, I will develop hemiplegia. You don't see me like morning I'm okay, evening only hemiplegia appears. So whenever a question says that weakness varies within one day, that is what we call as diurnal variation, it always indicates that patient has a neuromuscular junction disorder. Right? Diurnal variation, we will call it as the hallmark of neuromuscular junction disorder. And what are the neuromuscular junction disorders you know? Yes, myasthenia gravis and Lambert-Eaton myasthenic syndrome. So in myasthenia gravis, typically what happens, right, weakness is maximal by the end of the day, and in Lambert-Eaton myasthenic syndrome it is exactly opposite of it. Both of them have diurnal variation. The weakness is varying within a span of a day, but in Lambert-Eaton myasthenic syndrome, weakness is maximal in the morning, and as the day progresses, it improves in the morning, and as the day progresses, it improves. So the moment I see that there is diurnal variation, I will choose one of the neuromuscular junction disorders. If both options are there, like myasthenia gravis and Lambert-Eaton, I will see when the weakness is maximal. In myasthenia gravis, weakness is maximal in the end of the day. Why that happens? Because in myasthenia gravis, patients' neurons are fighting with the antibodies. There is a competitive inhibition. There are antibodies which are inhibiting the acetylcholine receptors. So in the morning, we have a lot of acetylcholine synthesized overnight, stored in the secretory vesicle. So in the competition, the acetylcholine wins and it will go and bind its receptor and we will be able to contract the muscles. As the time progresses, we start losing the acetylcholine because we are using it as a neurotransmitter. Acetylcholine levels start depleting, antibody levels remain same. Somewhere down the line, antibodies will exceed the acetylcholine, they win the battle and they will not let the acetylcholine bind its receptors and weakness starts appearing, right? So for this question, the answer will be option A, which is myasthenia gravis. Okay, next question, pretty interesting, and you might see that some of your colleagues, batchmates also suffer from this. Carpopedal spasm was developed in a woman suffering from hysteria when she was hyperventilating. What could be the cause for this? So what is the first diagnosis here? Where do we get carpopedal spasm? Carpopedal spasm. Where do we get it? Where do we see carpopedal spasm? What is carpopedal spasm? Spasm of the small muscles of the hand giving an appearance like this. We call it as carpopedal spasm. Right. We see that in patients with hypocalcemia, right? Which is generally due to hypocalcemia. Why that happens? Because under low calcium, your neurons are hyperexcitable. So they will send lot of signals and these muscles go into hypercontraction, and that is why we end up getting carpopedal spasm. Okay. What do we call this sign as? Carpopedal spasm. There is a name given to this sign. What do we call it as? We call it as Trousseau's sign. Trousseau's sign, right? Okay. Now, Trousseau's sign is basically the carpopedal spasm which we bring about by inflating the BP cuff above the systolic pressure. If it is directly present, we will simply call it as carpopedal spasm. And in books, we use it interchangeably. Trousseau's sign is equal to carpopedal spasm. All are fine. Okay. There's one more sign you get in hypocalcemia, where if you tap the patient's face, you will notice there is twitching. What do you call that sign as? Mechanism of that is also same. The neurons are hyperexcitable. You tap, you're stimulating the neurons, they will fire, send the acetylcholine to cause muscles to contract, right? We call it as Vostek sign. C generally is silent there, CH is silent. The usual pronunciation is Vostek sign. Let us Indianize it and call it as Chostek sign, absolutely fine. Okay, so now this patient has developed hypocalcemia and she is a known case of hysteria. Okay, now tell me what is the link between hysteria and hypocalcemia? Normally what happens is when we are facing some stress and we are prone for hysteria, we start hyperventilating. So we call that as hysterical hyperventilation. It's called as hysterical hyperventilation. Now please remember, when I increase my respiratory rate, I throw out a lot of carbon dioxide. And if I throw out a lot of carbon dioxide, what am I losing from the body? What am I losing from the body? Carbon dioxide, when dissolved in water, what does it become? Carbon dioxide, when dissolved in water, what does it become? So hyperventilation leads to carbon dioxide wash out from the body, right? So when I lose carbon dioxide, right? Carbon dioxide, when dissolved in water, becomes what is called as carbonic acid. So when it is inside the blood, it is mostly existing as carbonic acid. So if I lose carbon dioxide, I am losing carbonic acid. So what does that mean? I am losing an acid. So if body has a normal pH range of 7.35 to 7.45, this balance is maintained by number of base and number of acids. So if I decrease the acid, base remains same. What happened now? What will be the pH? pH will tilt towards alkalosis, right? So because of the CO2 washout, first thing I can develop is alkalosis. And because this problem is arising out of a respiratory dysfunction, we will call it as respiratory alkalosis. Respiratory alkalosis. Okay. Now, when I lose carbonic acid, what did I lose? Did I lose positively charged ions or negatively charged ions? When I lost carbonic acid, did I lose positively charged ions or I lost negatively charged ions? See, basically acid moieties exist as the negatively charged ions. So I lose negatively charged ions. And when we lose negatively charged ions, I have to also reduce the positively charged ions in the blood. Because otherwise, see, I am basically creating a potential difference. There are more positively charged ions, less negatively charged ions. This is what we call as potential difference, or an electricity. This is becoming a action potential, which is not required inside the blood. So if I decrease negatively charged ions, I have to decrease the positively charged ions also. Now, what are the major positively charged ions in the blood? Sodium, potassium, calcium, right? So if there is decrease in negatively charged ions, I have to decrease positively charged ions, which is sodium, potassium, calcium. So now to maintain this electrical neutrality, sodium, potassium and calcium will shift from blood to intracellular compartment. And once, see, sodium or potassium, small amount of shift will not make a difference. But when calcium shifts from extracellular to intracellular compartment, what happened to the blood calcium levels? Blood calcium level will decrease, right? So there is shift of calcium from extracellular compartment, means from blood, to intracellular. All the calcium is moving inside the cells. So now that has resulted in hypocalcemia, and that is why we will be seeing the symptoms of hypocalcemia in these patients. So now for this question, what should be our answer? Patient has developed respiratory alkalosis. So that will be our answer. Before we move forward, I have one last question. How do I treat these patients who has developed respiratory alkalosis? How do I treat them? Like not respiratory alkalosis, I don't want to generalize it. For a patient with hysterical hyperventilation, how do we treat? See, many medical students I have seen as patients with hysterical hyperventilation. Tomorrow, day after tomorrow is exam. Today they come to the emergency room saying that, sir, I can't breathe, I'm having so many issues, I have tingling sensations all over, and then they have carpopedal spasm. And then I know the student, So I will quickly think that this is not an endocrine disorder. The patient is not having hypoparathyroidism. First thing that would come to my mind is that, oh, yesterday I had taken a class for her, she was doing fine. Today she has come with these symptoms. Most likely it is hysterical hyperventilation, right? So we make them breathe in a closed bag. So we call it as closed circuit breathing or a closed bag breathing. So we generally don't have the properly designed closed circuits in our emergency room. So what we do is we give them a paper bag or a polythene bag and ask them to breathe in it. Because this hypocalcemia is a result of carbon dioxide washout. So if I give more calcium to this patient, what will happen? I give more calcium, patient continues to hyperventilate, continues to throw out carbon dioxide. Whatever calcium I give, that will also shift into the intracellular compartment. The best is to treat the problem, increase the carbon dioxide. So if the patient starts breathing in a closed bag, whatever carbon dioxide she is throwing out, she will inhale back. So slowly blood carbon dioxide level will start going up. So the negatively charged ions are going up, carbonic acid ions are going up. So calcium from intracellular will come out to the extracellular compartment and the blood calcium level will be normalized. So that is why we say treatment is closed circuit or breathing in a paper bag. Apart from that, yes, hysteria, obviously we should refer to a psychiatrist and they will take the further action. But this hypocalcemia should not be treated with calcium supplementation. Simple. Okay. Your drug of choice, absolutely right. Okay. Now let's go to the next question. A woman is admitted with persistent vomiting and is a known case of diabetes. History of consuming outside food was given. On evaluation, blood pressure is 90/60. Slightly hypotensive. Her ABG report shows the following findings. What is the cause of her ABG findings? Okay, so now when you look at the ABG, what is the pH? pH is 7.52. So is that acidosis or alkalosis? The normal range of the pH is 7.35 to 7.45, right? So when it is more than 7.45, we call it as alkalosis. And when it is less than 7.35, we call it as acidosis. So one quick look at the pH, we know that we are talking about alkalosis, right? So I don't need to further analyze my ABG because I will be able to rule out some of the options. And please remember this in mind. In the exam also, don't always waste time on the question too much. See, now I can definitely analyze this ABG, decide about compensation, whether it is appropriate, inappropriate. But is that expected from me on this question? No. So what should I do? The moment I read that the question is about ABG, my eyeball should take me to the options and understand what examiner is looking at. Examiner is asking simple question it is, right? So once I see alkalosis, some of the options are ruled out. The diabetic ketoacidosis is ruled out. Renal tubular acidosis is ruled out. There is no acidosis here. We have alkalosis. So I am only left with two options, septic shock and persistent vomiting. Now tell me what happens in septic shock. Septic shock basically means you have sepsis, which has resulted in shock. And because of the shock, there is tissue hypoperfusion, right? So when tissues are not getting sufficient blood supply, that means they are not getting sufficient oxygen. So when they are not getting sufficient oxygen, how do they survive? They switch their metabolism from aerobic to anaerobic metabolism. And when we go into anaerobic metabolism, we generate lot of lactate, right? Lactate is basically an acid. Lactate ion is an acid. So we develop basically lactic acidosis itself. So septic shock also leads to lactic acidosis. And for that matter, all shocks, whenever you have shock or hypotension, you have hypoperfusion of the tissues, and those tissues which are not getting sufficient oxygen, sufficient blood supply, they change their metabolism from aerobic to anaerobic, generate a lot of lactate. So all shock patients end up developing the lactic acidosis, which is again an acidosis. So what are we left with? Only one option is left, which is persistent vomiting. So whenever we have persistent vomiting, right, in the vomitus, we end up losing hydrochloric acid, which is synthesized in the stomach. With that, we lose the chloride ions, right? With that, we lose the chloride ion. That's why we get hypochloremia that you see here. And patient might often lose other electrolytes, and that is why we have seen here hyponatremia and hypokalemia. So this is a typical metabolic alkalosis, right? So this is a hypochloremic, hypokalemic, metabolic alkalosis. That's the diagnosis which can happen in patients with persistent vomiting, and that's why option C would be the answer. Even if you don't know the mechanism, you still know that the other three are not likely, so option C would still remain our answer. Okay, now the next question. A chronic renal failure patient who was on dialysis was brought to casualty when he collapsed suddenly. On examination, he had labored breathing. ECG shows tall tented T waves. Where do we get tall tented T waves? Where do we get tall tented T waves? Two conditions. Tall T waves, I want you to remember only two conditions. One is called as hyperacute T waves, which you see as the earliest sign of MI. Second is tall tented T waves, which you get in hyperkalemia, right? So this suggests that patient has got hyperkalemia. Okay. Next thing, what is the most likely acid-base imbalance that can be seen in this patient? What is the most common acid-base imbalance seen in patients with kidney disorders? Kidney disorders, CKD, what do we get? Chronic renal failure patients, the most common acid imbalance that is seen is the metabolic acidosis. Metabolic acidosis. So most common acid-base disorder in CKD patients is metabolic acidosis, right? Metabolic acidosis. So now just pick up the right answer. Which one is suggestive of metabolic acidosis? See, option C is something that I can comfortably rule out because the pH is on the alkalotic side, right? So now choose the rest of the options. Can it be option A? pH is 7.4, bicarb is 27 and PCO2 is 40. So this appears to be a normal ABG, right? Bicarb appears normal, PCO2 is in the normal range, pH is also in the normal range. So that's a normal ABG. So I am left with option B and D, right? So what do you get in option B? What is the acid-base disorder? I think all of you are familiar with this criteria called as ROM or ROMS for deciding what type of ABG abnormality it is, right? It simply means respiratory opposite, metabolic same. So all you need to do is look at the pH and PCO2. If they are in the same direction, it is it's a metabolic pathology, metabolic same, and if they are in the opposite direction, we call it as respiratory pathology, right? So let me analyze option B first. pH is in option B decreased, right? Less than 7.35. That's why it is acidosis. And what is happening to the PCO2? PCO2 is also decreased, right? PCO2 is also decreased. So that means this patient is having metabolic acidosis. This patient is having metabolic acidosis because if pH and PCO2 are in the same direction, it is a metabolic disorder. Then what about option D? In option D, pH is decreased, PCO2 is also decreased. This patient is also having a metabolic acidosis. Now the only difference I have to make is about bicarbonate. What should happen to bicarbonate in a patient with chronic renal failure? What should happen to bicarbonate in a patient with chronic renal failure? Bicarbonate needs to be reabsorbed after the filtration. Once we filter it, it needs to be reabsorbed by the kidney. And if it is a chronically failed kidney, it will not be able to reabsorb it. So in that case, the bicarbonate would be decreased, right? We have failure to reabsorb the bicarbonate because of chronic renal failure. So then what should be my answer here? It will be option D. Option D fits into the bill. Everything is suggestive of chronic renal dysfunction. So we'll go ahead with option D. Clear? Okay. Now we have a next question. The woman presented with the feeling of tightness on her face. Okay, this is a very simple and straightforward question. A woman presented with feeling of tightness on her face and numbness of her fingertips. ANA is found to be positive. ANA is found to be positive and immunofluorescence shows nucleolar pattern. What is the likely diagnosis? What is the likely diagnosis? What do you think is the finding here? What is it suggestive of? Right, so what we see here is the tightness of face, right? What does that indicate? There is fibrosis of the skin, right? Numbness of fingertips. What is it suggestive of? It is suggestive of what we call as Raynaud's phenomenon. It is suggestive of Raynaud's phenomenon, right? So patient with the skin sclerosis, right? Sclerosis or fibrosis of the skin with Raynaud's phenomenon, the first thing that should come to our mind is systemic sclerosis. Now the question is, can ANA be positive in a patient with systemic sclerosis? Or should it only be positive in the SLE? Should it only be positive in patients with SLE? So please remember guys, ANA is not a very highly specific investigation. It can be positive in various disorders. Even 5% of general population, when you take the titer of 1 in 40, it can be positive. That is why even when we go to SLE, we specifically mention what is the cutoff to say that it is relevantly positive. That is 1 in 80 titer with an investigation done as indirect immunofluorescence, right? Only then it makes some sense to us. And we use ANA only as a screening tool for the diagnosis of SLE. It is not the most specific antibody. What is the most specific antibody in SLE? It is anti-Smith antibody, right? And what is the most second most specific antibody? That is anti-dsDNA. And what is the most sensitive antibody? ANA, because we are using it as a screening test. The second most sensitive antibody in SLE is anti-dsDNA. That's why we say anti-dsDNA is the perfect antibody which will help us diagnose as well as understand the prognosis in patients with SLE, right? So just because ANA is positive, it doesn't mean that we're talking about SLE. The answer is right. We should be thinking of systemic sclerosis. Okay. Next question. I should ask you, what is the most common cause of death in patients with systemic sclerosis? That is again an important MCQ point. What is the most common cause of death in systemic sclerosis? The most common cause of death in systemic sclerosis is not exactly cardiac failure. Most of these, the terminal event is cardiac failure, but what they develop is pulmonary arterial hypertension, followed by, they can also develop interstitial lung disease. So pulmonary arterial hypertension is the most common cause of death. As you know, the pulmonary arterial hypertension will lead to right heart failure and they can die, but the main disease is pulmonary arterial hypertension. Okay, next. A woman in her mid-40s who has a known case of hypertension was brought to the emergency room with loss of consciousness, chest pain and diaphoresis. Okay. Now can anybody tell me the differential diagnosis for a known hypertensive presenting with chest pain, LOC and diaphoresis? What is diaphoresis? Profuse sweating. Gautam Fulara, the scleroderma renal crisis is no longer the most common cause of death in systemic sclerosis, because what is scleroderma renal crisis? Nothing but a high renin hypertension, right? So we can effectively treat it with AC inhibitors or ARBs and nitrates. We can lower the BP and we can reduce the progression of renal failure. It's not a very difficult to treat disorder anymore. So it's no longer a major contributor to mortality. It is the pulmonary arterial hypertension followed by ILD, which are the contributors to mortality. Right. So first thing is, whenever someone presents with chest pain, your first differential diagnosis should always be myocardial infarction, because that's the most common major disorder. Right. From the story, you are absolutely right. This is suggestive of aortic dissection. But for me, first thing that should come to my mind is MI, followed by that other causes like acute pericarditis, Boerhaave syndrome, Mallory-Weiss-Terr, pneumonia, costochondritis. Differential diagnosis will go on and on. And in the question, my first attempt should be to rule out the possibility of MI, right? Which I get some clues here. First clue is that patient's pulses were bilaterally unequal and she was unstable. A patient of MI can also be unstable, but unequal pulses is something that is making me think of aortic dissection, right? That is one point. Second, they say that there are ECG changes, but they are non-specific. So at least STEMI is something which is ruled out. NSTEMI is still a possibility. But given the fact that they are talking about unequal pulses, I would consider my diagnosis here as the dissection of aorta. Dissection of aorta. Now the question is, what is the investigation of choice if you are suspecting the aortic dissection? Investigation of choice. Please remember, the investigation of choice is the CT angio. CT angio is the investigation of choice, which is not there in our options. Okay. So if CT angio is not available, then what is the next thing I can think of? It is doing a transesophageal echo. If I do cardiac enzymes, it will come abnormal, but that will not help me to differentiate between MI and the aortic dissection, right? Chest X-ray is of no use and MRI is of no use, but MR angio may be helpful. I have to do a angiography to see aorta from where it is dissecting, where the bleeding is happening. Right, so CT angio is the investigation of choice, and as an alternative, when CT angio is not feasible for whatever reason, you can go for the transesophageal echocardiography. Transesophageal echocardiography, which is TEE, transesophageal echocardiography. Now obviously TEE is a cumbersome procedure and it need not be suitable for all individuals, and it requires an expertise, right? You need a cardiologist who is an expert in doing transesophageal echocardiography, so it is not always available, not always feasible. For most patients, CT angio is the ideal investigation, and definitely we can do CT angio even in patients who are stable as well as unstable. Transesophageal echocardiography may be difficult to do in patients with the unstable patients, because unstable patient, this is an invasive procedure, right? We need to put the echo probe into the esophagus where we can stimulate the vagus nerve, and if we end up stimulating the vagus nerve, it can cause further hypotension. Nowadays we generally do not rely much on transesophageal echocardiography, but because CT angio is not mentioned as an option, I will be choosing C, transesophageal echocardiography, as the answer here. Okay, next. A patient presents with a seizure. On evaluation, urine osmolality is 100 milliosmoles per kg and a serum osmolality is 270 milliosmoles per kg, expected electrolyte abnormality. So first let us understand what is the normal serum osmolality. Normal serum osmolality is in the range of 280 to 294 milliosmoles per liter, right? Milliosmoles per liter. Okay, and what are the major contributors to serum osmolality? If you remember the formula for serum osmolality, you know what are the major contributors. It is 2 into serum sodium levels plus glucose, blood glucose basically, divided by 18 plus blood urea nitrogen divided by 2.8. This is the formula for calculation of serum osmolality. What does that mean? We have three major contributors to serum osmolality. When any of these levels decrease, it will have an impact on the serum osmolality. If blood glucose level significantly decrease, or blood urea nitrogen level significantly decrease, or sodium. If I ask you to pick one major ion which is contributing to serum osmolality, what will be your answer? Whatever is glucose reading, we are dividing it by 18. Whatever is your blood urea nitrogen reading, we are dividing it by 2.8. But what are we doing with sodium? We are multiplying it with 2, right? And what is the normal sodium value? Normal sodium value is in the range of 135 to 145 millimoles per liter, right? So even if I take the median value of 140 and multiply it with 2, how much I get? 2 from sodium. And only remaining osmolality is coming from glucose and blood urea nitrogen, right? So whenever osmolality decreases, that means most likely sodium would be decreased. So that's why we should choose option A as the answer here, suggestive of hyponatremia. So that means this patient is probably losing a lot of sodium in the urine. That's why his urine osmolality is high, resulted in hyponatremia, making his serum osmolality lower than normal. So all of you are right. Aris, Sanjay Singh, right. Hyponatremia would be the answer. Okay, next. Clinical presentation with feeble femoral pulses associated with upper limb blood pressure of 185/90 and chest X-ray showing enlarged intercostal arteries. What is the likely diagnosis? It's a simple straightforward story which you have been studying from your first MBBS itself, right? You hear this word in the first MBBS itself. So what this story is suggestive of? Femoral pulses are feeble, right? That means less blood is going to the femoral arteries. But upper limb BP is high, that means more blood is getting pushed into the upper limb vessels. And chest X-ray shows enlarged intercostal arteries. Ideally, they shouldn't say enlarged intercostal arteries. We can't see it on the chest X-ray. They should have said that there is rib notching. There is rib notching. Right. So this is the story of typical case of coarctation of aorta. Coarctation of aorta. It's a simple case-based story. There is nothing confusing here. Option C will be the right answer for this question. So whenever we have coarctation of aorta, you can get the rib notching like you see in these images. I don't have a very high resolution image, but I will definitely bring in a high resolution image and post it on the social media where you can clearly see the rib notching. Okay. Now, this is a bit interesting question. A patient has undergone a circumflex artery bypass. Okay. Before I go further, right, can I ask you which part of the heart the circumflex artery gives the blood supply? Which part of the heart the left circumflex artery gives the blood supply? Circumflex artery is primarily responsible for supplying the lateral wall of the heart, supplies lateral wall of the heart and to some extent inferior wall of the heart. Okay. So this patient had developed the block in the circumflex artery. So that means the posterior, inferior and the lateral wall. The main supply to lateral wall is the left circumflex artery. It arches behind, supplies a little bit of posterior wall and then anastomosis with the tributaries coming from the right coronary artery, and thus it is contributing a little to the inferior wall also. Okay. So that means this patient would have most likely presented with the lateral wall MI, right? So this patient has undergone a bypass, who is a known case of atherosclerosis. Stent placement was successful. This question is not well designed, to be very frank, but this is how students have recalled. On one side we say bypass, on the other side we say stent. Regardless of that, he was already taking lisinopril, verapamil, metoprolol. Which drug should be added? How do we treat a patient with ischemic heart disease? What all drugs we would give for a patient with ischemic heart disease? We will give antiplatelets, right? Antiplatelets. Antiplatelets. Second, we will give beta blockers, right? Third, we can think of giving ACE inhibitors or ARBs, mainly if there is a need for regulating the blood pressure, right? Then we can think of giving nitrates. These are commonly used drugs. Okay. Now here, patient is already taking lisinopril. That means an ACE inhibitor is already in place, right? Patient is taking metoprolol. That means beta blocker is already in place. Nitrates are mainly for symptomatic treatment. Whenever there is an angina, patient can use a sublingual nitrate. If it is a chronic stable angina, we can also consider nitrates. Okay. Now what I need to add here, the patient definitely needs antiplatelets to be initiated. Two questions here. If I am giving antiplatelets, whether I should give 1 or 2, and second one is how long. I know all of you know the answer. The question is 1 or 2 and how long. Right. So there is no role of anticoagulants in a patient with ischemic heart disease. That's very clear. We will only treat them with antiplatelets. Anticoagulants will come into picture only if you are dealing with a case of NSTEMI, right, or non-ST elevation acute coronary syndromes. So it will be P2 𝐌12 blocker will be the right answer here. Antiplatelets, we give dual antiplatelet therapy, which stands for 2 antiplatelets for 1 year, and then it will be followed by, after an MI we give 2 agents like aspirin plus clopidogrel for 1 year. After that, we will switch to single antiplatelet therapy, which will be for lifelong. A patient with an ischemic heart disease is supposed to be on antiplatelets lifelong. First 1 year, 2 agents, right? So one of them is a thrombexin A2 blocker, which is aspirin. The second one is the P2Y12 blocker, which is clopidogrel. So here P2Y12 being a antiplatelet, that will be the answer. Example being clopidogrel, other examples being ticagrelor, right? That's also a P2Y12 blocker. Okay, just asking you out of curiosity, in which phase of forming a platelet plug P2Y12 blockers are helpful? Do they prevent platelet adhesion or do they prevent platelet aggregation? Do they prevent platelet adhesion or do they prevent platelet aggregation? So just drop down your comment. I will take the next question now. All of the following statements are true regarding pheochromocytoma except. Gautam Fulara, absolutely right. So normally what happens is once we create an endothelial injury, right? Let me say that this is a blood vessel where I have caused an endothelial injury, and from the site of injury I will start bleeding. Now to contain this bleeding, I have to patch this up. How do I do? First thing I do is cause what is called as platelet plug formation, which includes 2 major steps. The first step is platelet adhesion. How do the platelets get to know that, okay, I have to go here and adhere to the endothelium? Whenever there is endothelial injury, we expose what we call as von Willebrand factor. So platelet will come and bind to it. That is how we create platelet adhesion, attachment of platelets. But this few platelets is not sufficient. I need to involve more platelets. So how do I involve more platelets? If I create only small set of platelets there, it may not be enough. The flow of blood will wash them away. So these platelets secrete messengers, which are nothing but thrombexin A2 and ADP. These are strong platelet attractants. So thrombexin A2 and ADP will attract more platelets. But when more platelets come to this site, they can't bind to von Willebrand factor, because whatever von Willebrand factor was there, it has been already occupied by the existing platelets. So what should they do? They should bind with the existing platelets to create a plug. How do they bind? Basically, they bind with the help of the receptor that we call as P2Y12. Right? So P2Y12 helps us in binding more platelets to existing platelets. So first step where platelets came and got attached to von Willebrand factor, it is called as adhesion. Second, when more platelets come and bind to each other, we call it as aggregation. Aggregation is facilitated by P2Y12, right? And how these patients are calling the other patients by platelets by sending thrombexin A2 and ADP. Okay, so if I have to stop platelet plug from formation, I can block thrombexin A2 by giving aspirin. So if I give aspirin, the platelets who go and attach initially, they can't send thrombexin A2, so they can't attract more platelets. That is one mechanism. That is how aspirin becomes an antiplatelet. Second, if I block P2Y12, even if thrombexin A2 is produced, more platelets come to the site, they can't bind with the other platelets because their receptors are blocked. That is how clopidogrel or ticagrelor works, right? Okay. Now this is our next question. All of the following. Yes, so clopidogrel inhibits platelet aggregation. Aspirin inhibits platelet aggregation. Nothing is inhibiting the adhesion. But in von Willebrand disease, adhesion doesn't happen. All of the following statements are true regarding pheochromocytoma. Right? What are pheochromocytomas? These are tumors originating from what tissue? Pheochromocytomas are tumors secreting catecholamines, right? What are the catecholamines we know? Adrenaline, noradrenaline, and dopamine, right? Now from where these tumors can originate? There are only 2 structures from where these tumors can originate. One from the adrenal medulla, from which generally we produce adrenaline, noradrenaline, dopamine, and then you have this sympathetic ganglia, right? So when tumors originate from the adrenal medulla, we specifically call them as pheochromocytomas. When they originate from the sympathetic ganglia, we can either call them as extra-adrenal pheochromocytoma, or you can also call them as paragangliomas. Basically, they are originating from the ganglia. So you can call them as paragangliomas. The most common site being the organ of Zucker candle. Right. So all of you are right. Okay. So whenever we have pheochromocytoma, what is the most common presenting complaint of these patients? They usually present as episodic hypertension and palpitations. Many a times these patients are mistakenly diagnosed as having panic attacks because they come with palpitations and everything else appears normal, ECG shows sinus rhythm. So they get labeled as having an anxiety issue or a panic attack, and they get referred to psychiatrist. But every time he goes to psychiatrist, the psychiatrist notices that BP is quite high. And that is how he might sense that, okay, this is not a simple panic attack, something more sinister. He refers back to the physician, and this time the physician will start thinking, oh, I missed this. And then he will evaluate and he will get to know that it is pheochromocytoma. So patients develop, yes, the palpitations are because of tachycardia, episodic hypertension and episodic palpitation. Why it happens as episodes? Because the release of adrenaline, noradrenaline and dopamine also happens in bouts, secretory bouts. So whenever large bout of catecholamines come from the tumors, BP shoots up, heart rate shoots up. Patient will have profuse sweating. Okay. Now, what is the definitive treatment of pheochromocytoma? The definitive treatment, whether the pheochromocytoma is benign or malignant, is surgery, right? Is surgery. That is simple. But till we get the surgery done, patient will experience very high blood pressures and high tachycardia. Sometimes those high blood pressures can cause other consequences like hypertensive encephalopathy, hypertensive acute retinopathy, or intracranial bleed. So to avoid that, we have to first get the BP control before we operate, right? But how do we control? First, we have to initiate alpha blockade, and only 2 to 3 days before the surgery, we bring in beta blockade. So that is the basic thing, right? So when it comes to use of antihypertensives in these patients, the drug of choice is alpha blockers, and these are the ones should be started first, then followed by beta blockers later. Usually 2 to 3 days before the surgery, we bring in the beta blockers. So with this information, now give me the answer. What should be the right answer for this question? All of the following are true regarding pheochromocytoma except. Right, we can use phentolamine or phenoxybenzamine. Nowadays, we have started using like prazosin or other alpha blockers because they are more readily available. Right, so the answer would be option A. Propranolol will not be the first treatment. It will be an alpha blocker. Beta blockers will be brought in last, right? Surgical excision is the definitive treatment. That is true, 100% true. How do we diagnose? How do we diagnose? Can I diagnose by estimating catecholamines? Not a good idea. Why? Because they are released in secretory bouts. So if I estimate catecholamines during a secretory bout, it will be high. Between two secretory bouts, it may be normal. But I can estimate their metabolic end products. What are the metabolic end products? There is an enzyme called dopa decarboxylase which breaks them down into metanephrine and normetanephrine, right? They have relatively long half-life. Adrenaline, noradrenaline, dopamine, they have short half-life. So when they come, if you check it, it will be high. After that, once their effect is gone, it will be normal. But once they are broken down, the metabolites will remain in circulation for a long time. That's why we rather use the metabolites for diagnosis, which is metanephrine or normetanephrine. In the past, we used to use vinyl mandelic acid also, which is not as sensitive as the metanephrines or normetanephrines. But it is kind of true statement, so I will agree, but I want you to remember that preferred investigation for screening is not vinyl mandelic acid. It is going to be urine metanephrines or normetanephrines. Urine metanephrines or normetanephrines. Those will be the preferred investigations for initial screening. And once you find that they are high, then we have to do the CT scan or the other nuclear imaging to identify where is the tumor, whether it is in the adrenal medulla or the extra-adrenal sites. Okay. Can present as hypertension alone? Yes, many patients develop only hypertension, and sometimes with vomiting and abdominal pain. Yes, that is because you can develop the vasoconstriction. The mesenteric vasoconstriction can trigger the mesenteric ischemia and abdominal pain. Why are they developing vasoconstriction? Because adrenaline, noradrenaline, they are vasoconstrictors. Okay. Next, what should be the first line of treatment for a patient diagnosed with giant cell arteritis? First line of treatment for a patient diagnosed with giant cell arteritis presenting with headache, jaw claudication, polymyalgia rheumatica and mononeuritis multiplex. See, you can initiate beta blockers slightly early if the patient, we are in a crisis situation, but still alpha blockade first. Only when you are convinced that we have achieved sufficient alpha blockade, we can bring in the beta blockers. Okay. So this question is talking about giant cell arteritis. They have given the diagnosis and they have also given the key clinical features that we generally see in patients with giant cell arteritis. So what is the drug of choice? Right, the drug of choice for giant cell arteritis and the first line management is steroids. We do add aspirin because there is a risk of blockade, there is a risk of retinal artery occlusion, patient can lose vision. So that's why we do add steroid, but specifically speaking, the drug of choice is steroids, right? So steroids will be the answer to go for. This question is straightforward about giant cell arteritis, but if they fail to respond, we can bring in tocilizumab or abatacept. So these will be considered as second line agents. Second line agents. Can anybody tell me the mechanism of these two drugs? Aspirin is add-on therapy, means we add it in addition to steroids to decrease ischemic events. We add aspirin. So generally what we do is we start steroids and aspirin. If events go on or the disease does not respond, we can use either tocilizumab or abatacept. Right. So tocilizumab is a monoclonal antibody against, it blocks interleukin 6, right? Where else did we use tocilizumab in the recent times? Right. It's a CTLA immunoglobulin. It's a CTLA immunoglobulin. Abatacept is a CTLA immunoglobulin. Okay. Where did we use? Right. In COVID, we were using, because in COVID we had a situation called as cytokine storm. So those patients had very high levels of interleukin 1 and interleukin 6. Such patients had a higher risk of mortality because they had multi-organ inflammation, multi-organ failure, and the risk of death was high. So we were trying to inhibit the interleukin 6 so that we could save the other organs, right? Okay. Next question. A 49-year-old man presented with history of recurrent retrosternal chest pain. Recurrent, they have mentioned recurrent, retrosternal chest pain with each episode lasting 3 to 5 minutes and subsiding with sublingual nitrate. ECG shows left ventricular hypertrophy and flat T wave. He is known case of hypertension, diabetes and hypercholesterolemia, currently on aspirin, atenolol, metformin and lovastatin. What is the next best step in the management? So now tell me the diagnosis. We all know the chest pain here is referring to myocardial ischemia. The story is of angina. Should I call it as stable angina, unstable angina, non-ST elevation MI or STEMI? Right. So this is a case of angina. Stable or unstable? Yes, this is angina. The question is stable or unstable angina. Right. This is stable angina. So when do you call it as unstable angina? Unstable angina refers to if patient develops angina at rest. Okay. Number 2, if patient develops angina after exertion, but angina that is not relieved by rest or nitrates within 5 minutes. within 5 minutes. So it should take less than 5 minutes for you to get relieved of. If it is taking more than 5 minutes, it is getting relieved with rest or nitrates, but taking more than 5 minutes, then also it will be called as unstable angina. Anything that gets relieved in 5 minutes time, we will be considering it as stable angina. So here this question is suggestive of stable angina. So for me, the diagnosis here will be stable angina. So when we recall this question, there were two theories. One student said that, sir, they had mentioned that the angina episode started typically at rest. In another set of students said no such statement was there. So if I add a statement saying that this patient's current episode of angina appeared at rest, it becomes unstable angina, right? That statement has not been added in this question, so I will consider it as stable angina. It's a case of stable angina, which is unfortunately not controlled with the medications that we give. So whenever we have stable angina, how do we treat them? The treatment of stable angina goes like this. There are two things we need to achieve. First one, we need to have a symptom control, right? So what can I use for symptom control? Because these patients are experiencing repeated episodes of angina that is limiting their physical activities. I can't walk 100 meters because before that the chest pain will come. So how can you help me come out of these symptoms or reduce the symptom frequency? And second thing I need to do is, because now that they have stable angina, that means their coronaries are narrowed. In future, they are definitely going to develop an MI. So how can I prevent it, right? How can I prevent it? Prevention of MACE. MACE stands for major acute coronary events, which is nothing but an MI. So for symptom control, I have to do vasodilatation. The coronaries are narrowed, tissue is getting less blood supply, so patient is experiencing angina after physical activities. I dilate the blood vessel, more blood will reach the myocardium and the symptoms will come down. So how can I high dilate? How can I dilate? Yes, I can use beta blockers, right? I can use calcium channel blockers and I can use nitrates. These can cause the vasodilatation and have a better symptom control. How can I prevent a future MI from happening? By giving antiplatelets and statins, right? So by giving antiplatelets and statins, these can help me to have a better risk reduction of future MI. Now in this case, what I have just told, that patient has presented with history of recurrent retrosternal chest pain. Basically, we are talking about a stable angina where the angina episodes are not controlled. So that means we have not achieved the optimum symptom control, right? We have not achieved optimum symptom control. Okay. Now what is missing from his treatment? Is he on antiplatelets for secondary prevention? Yes, he is on antiplatelets, right? Is he on beta blockers? Yes. He is diabetic, so he is on metformin. He is on statins for the risk reduction of MI. Only thing I should do now is either I should add a calcium channel blockers, right? I should add a calcium channel blockers or the increase the dose of beta blockers. Please remember, nitrates as sublingual or IV are useful in acute ischemic heart disease, like when you have a unstable angina, when you have NSTEMI or when you have STEMI. When you have an MI or unstable angina, in acute conditions, we use sublingual nitrates or IV nitrates. The oral nitrates are not as effective as beta blockers or calcium channel blockers when it comes to control of the symptoms. Right, so what I should choose here? IV glyceryl nitrate infusion is for unstable angina or NSTEMI or for patient with STEMI. In other words, I will call collectively all of these as acute coronary syndromes. It is not for a chronic stable angina patient, right? I can't put a IV like nitrate infusion and send the patient home and be on the infusion forever. Not possible, right? Okay. Adding clopidogrel is not warranted here because for a patient with chronic stable angina, generally we don't consider dual antiplatelet therapy. You can choose either aspirin or clopidogrel. When you have an MI, that is where we think of dual antiplatelet therapy for 1 year, followed by that again we switch to single antiplatelet therapy for lifelong. So patient is already on aspirin, so why should I think of adding a clopidogrel? No, right? Then some of you may be thinking injection enoxaparin, which is an anticoagulant. In acute coronary syndromes or in ischemic heart disease, generally speaking, where do we use anticoagulants? We use in patients with unstable angina and non-ST elevation MI. It is not used for a patient with chronic stable angina. So here I will be choosing option A as the right answer. Option A as the right answer. Injection enoxaparin will be for unstable angina and non-ST elevation MI. But if I just mention one statement here saying that this patient, he is now presented with an angina which started at rest, or this time it is not relieved within 5 minutes. He has taken nitrates but it is still not relieved. The diagnosis flips now. The diagnosis becomes unstable angina, right? So in that case, the mainstay of treatment for unstable angina would be to give anticoagulants. Nitrates are mainly for reducing the pain, but the mainstay of treatment will be anticoagulation, and then the answer becomes option B. If I make the diagnosis unstable angina, answer becomes option B. If I keep it a stable angina, answer becomes option A. And it is all play of words. So I also don't know exactly how this question appeared in the NEET PG, whether it was pushing towards unstable angina or stable angina, because we got two types of recalls, right? Until and unless you know the story, you don't know the story, you will not be able to get the answer right. So please be aware how to recognize unstable angina. Unstable angina, angina that occurs at rest, or angina that is not relieved by rest or nitrates within 5 minutes. Okay, now going to the next question. A known case of diabetic who is non-compliant with medication presented with vomiting and abdominal pain. On examination, patient is dehydrated. So is a known diabetic, dehydrated, presented with vomiting and abdominal pain. RBS is 500 milligrams per deciliter and ketone bodies are positive on the dipstick. So what is the diagnosis here? The diagnosis is pretty straightforward. We are talking about diabetic ketoacidosis, right? Ketones are positive, patient is dehydrated, sugars are more than 250, so it is DKA, right? How do we treat diabetic ketoacidosis? So please remember, whenever we have diabetic ketoacidosis, majority of the patient will be profoundly dehydrated, right? So the average fluid deficit in a patient with DKA means by the time they come to hospital, right, the fluid deficit is around 6 liters. Means they would have lost around 6 liters of body fluid before they reach hospital. Why do they lose so much of body fluids? The reason is simple. When blood sugar level becomes very high, we will have glucoseuria, right? When we have glucoseuria, glucose is an osmotically active substance. So it will not go alone. It will take water along with that. That is how we generally develop polyuria in diabetes. Now sugar more high, more water loss, patient will become dehydrated. Second thing is, now your tissues are not able to utilize glucose because there is deficiency of insulin. Insulin is required for tissues to be able to utilize glucose. Your blood glucose level is very high, but your tissues can't use it. So if they are not able to use, what will happen to their metabolism? They will switch to anaerobic metabolism, right? So they will start generating and they will start using fatty acids as the source for energy. From there we start generating a lot of these ketone bodies. So that is why we have ketoacidosis and we have severe dehydration. So if I have to treat these patients, there are two things that I need to do. One, I have to address the dehydration. Second thing I have to do is I have to reduce, or I have to switch the metabolism from using free fatty acids as a source of energy to glucose. How can I do that? Tissues are not able to use glucose because insulin is not there or not sufficiently there. So I have to give insulin so that the tissues will start using glucose, give up on using free fatty acids, stop generating ketone bodies, right? So what should be the mainstay of treatment? It will be option C, intravenous fluids. And when it comes to insulin, now I need insulin which acts quickly, right? So I should prefer either short acting, ultra short acting or regular insulin, not the long acting insulin. So option C would be the right answer, as some of you have already mentioned. Insulin infusion alone is not enough. Intravenous fluids alone is not enough. We need intravenous fluids plus insulin, which is short acting, ultra short acting or regular. Long acting is not useful. Okay. Next question. The fluid analysis of cerebrospinal fluid specimen showed mononuclear cytosis and elevated proteins, low sugars, and microscopic picture is given below. What is the most likely diagnosis? So we can see from the picture that there is lymphocyte predominance, right, which is also mentioned in the questions. There are two potential clues here in this question for this patient with CSF abnormality. One is the low sugars, right, and the second one is this image that you can see here. So based on that, tell me what is your diagnosis, right? So this patient has lymphocyte predominant CSF picture. And where do we get lymphocyte predominant CSF picture? When we have viral meningitis, fungal meningitis and tubercular meningitis. Between these three, where do I see profoundly low glucose in the CSF? Whenever we think of low sugars in the CSF, I want you to think of either pyogenic or what you call as bacterial meningitis, pyogenic or bacterial meningitis, and second thing is tubercular meningitis. Rarely we can have low sugars in the fungal meningitis also, but these are the two most things that should come to our mind, bacterial meningitis and fungal meningitis. But obviously this is not bacterial meningitis, because in bacterial meningitis we will have neutrophilic predominance, right? That is clear. So I'm already thinking that this is most likely tubercular meningitis, and it becomes more consolidated once I see these web-like structures here, what you call as cobweb formation, right? So we call them as cobweb formation, which is typical of tubercular meningitis. So we will choose option D here, which is tubercular meningitis. Clear? Okay. Now moving on to the next question. Here there is a retropositive patient. What does that mean? We are talking about an HIV positive individual who is on HART, highly active antiretroviral therapy. What is the parameter that we use currently for the assessment of efficacy of the treatment? Whether I need to step up the medications, change the medications, how do I decide? What is the parameter that helps us to decide? So when I started my MBBS, the parameter used to be CD4 count. Later it became CD4 count and viral load. No, not the P24 antigen. Current NACO as well as the WHO guidelines recommend that once you start the patient on antiretroviral therapy, whether it is adequate or not, the decision will be based on the viral load, right? So the answer is option C. And this is as per the NACO guidelines, only selected patients. And if your answer is selected patients, what are the indications? What are the indications? Tony DB, I can see myself streaming flawlessly. So just refresh your stream. Should we start for all patients or selected patients? And if you say selected patient, then what are the indications? Yes. In the past, the decision to start antiretroviral therapy was based on the CD4 count. We used to start when I was studying when the CD4 count was less than 200. Till the time we were not starting the antiretroviral treatment. Every 6 months we used to monitor the CD4 count. But now we start on the day of diagnosis itself for all patients, right? So HART is now recommended for all patients. Why is it recommended for all patients? Because higher the viral load, more damage to CD4 cells will lose, immunity will slowly decrease, and all the complications will emerge. So if I keep the viral load low from the beginning, the chance of developing complications is less and patient can have a long life. And that is why in the recent times, like last 20 years, we have seen a significant jump in the life expectancy of HIV positive individuals. Many of them have completed a normal lifespan. Means people have lived till their 75 and 80 and then died because of natural age related diseases like MI or stroke or accidents without developing any complications of HIV. Right? So HART is now recommended for all patients. For all patients. Okay. Next question. What is the drug of choice for acute management of unilateral headache associated with nausea, photophobia, phonophobia in a female patient? So this is a story of what type of headache? See, when you say unilateral headache, what should come to your mind? Or at least what we can rule out? Unilateral headache rules out tension type of headache, because tension type of headache is bilateral, right? So please remember, the tension type of headache is bilateral. Tension type is usually bilateral. And then your migraine, and then cluster headache, then you have this thing called as SUNCT or SUNA, and paroxysmal hemicrania. These are common primary headache disorders which are unilateral. These are all unilateral. So how do I recognize whether patient has got migraine, cluster headache, or SUNCT or SUNA, or paroxysmal hemicrania? Generally questions will have clues. The clues towards migraine are presence of with or without aura. Patient may have or may not have aura, right? Then the second clue for migraine will be presence of photophobia, phonophobia. Photophobia and phonophobia. Apart from that, patients of migraine often have severe nausea or vomiting. The clue for cluster headache would be there is seasonal variation. There is seasonality to the episodes of headache happening in patients. Second, they have autonomic symptoms. They have autonomic symptoms. What are the autonomic symptoms? Like stuffiness of the nose, redness of the eyes, right? Rhinorrhea, lacrimation, flushing of the face. These are all autonomic symptoms which are often associated with cluster headache. When it comes to SUNCT or SUNA, and another important thing is that alcohol precipitates cluster headache. So whenever a question says that here is a patient with unilateral headache where alcohol is precipitating it, think of cluster headache. Okay, now you may say, sir, migraine can also be precipitated by alcohol. Generally, alcohol does not precipitate migraine. Once you drink, during the hangover period, migraine gets precipitated, not when you are under the influence. But the cluster headache, I drink today, after few hours, I will start developing cluster headache. Okay. Another thing is, cluster headache is more common in males than females. That's the only primary headache which is more common in males than females. Migraine, tension type, SUNCT, SUNA, everything is a disorder of females. Okay. SUNCT and SUNA, there are two clues. The first one is the headaches last for seconds, lasting for seconds. Right. Alcohol, males, obviously males are the ones who drink more. Second, SUNCT or SUNA often have cutaneous triggers. Right, or cutaneous touch, means if you touch their face, it precipitates the headache. Alcohol precipitates the headache in cluster headache. Touching the face precipitates the headache in SUNCT or SUNA. And the clue for paroxysmal hemicrania is that these patients have excellent response to indomethacin. Whenever a question says patient has got excellent response to indomethacin, think of paroxysmal hemicrania. So this question is pretty simple and straightforward. It is talking about photophobia, phonophobia, female, everything fits into migraine. And what are they asking? They are asking drug of choice for acute treatment, right? This is where many of us do a small mistake. Drug of choice for acute treatment, or it is preventive treatment. Here they are asking drug of choice for acute treatment. And what is the drug of choice for acute treatment of migraine? It is triptans, right? So that's why option A becomes the answer. What is the drug of choice for preventive treatment? Beta blockers, mainly propranolol, right? Even flunarizine and topiramate can be used for the preventive treatment. They are not used for the acute treatment. These are all used for preventive treatment of migraine, not for acute treatment. And as we know, propranolol is the drug of choice for preventive treatment of migraine. Preventive treatment of migraine. Okay, let's move to the next question now. Here a patient was brought by relatives with sudden onset breathlessness. He is a known case of hypertension who is non-compliant with medications. So please remember there is a risk factor here which is hypertension, and he is not taking antihypertensive medications properly. On chest X-ray, the picture is as shown below. What is the next line of management? Okay, I will show you the chest X-ray. So what do you see in the chest X-ray? We see what we call as pulmonary edema, right? So on the chest X-ray, we are seeing pulmonary edema. Some of you may not be able to see clear resolution of the image based on your YouTube settings. I will anyway post this on the Telegram where you can see the image. So this chest X-ray showing pulmonary edema. So if a hypertensive presents with pulmonary edema, what will be your diagnosis? Hypertension or hypertensive presenting with acute pulmonary edema. What is the diagnosis? The diagnosis is patient has developed what we call as left ventricular failure or acute heart failure, right? It means basically we are talking about acute heart failure. Now, how do I treat this patient? Will nebulization with salbutamol help them? No, right? Or intravenous salbutamol will help them? No, right? Oxygen antibiotics, do they have any role? There's not infection. So how do I help? See, there are two things I have to achieve. One, I should give diuretics to clear the edema. Second, I have to get the BP under control. How can I get quickly BP under control? By giving drugs which can be given as an IV route. Either nitrates like sodium nitroprusside or nitroglycerin can be used, or labetalol, which is another agent which can be used as IV. So here the only logical option is option B, which is intravenous nitroglycerin. Good. Okay. So here is our next question. A woman in her 30s presented with fever associated with night sweating. On examination, she has ptosis and bilateral facial nerve palsy. See, please remember, she is having fever, she has night sweating, and she has ptosis and bilateral facial nerve palsy. Investigation shows leukocytosis and bilateral hilar lymphadenopathy. Bilateral hilar lymphadenopathy. What is the most likely diagnosis? So if I eliminate some of the points mentioned here and ask you to concentrate on night sweats, fevers, and bilateral hilar lymphadenopathy, what disease should come to your mind first? Night sweats, fever, hilar lymphadenopathy. In India, what disease should come to your mind? It is tuberculosis, right? Tuberculosis. Now, tuberculosis is unlikely to cause ptosis or bilateral facial palsy. Sometimes a tuberculoma can cause microvessel infarcts of the optic nerve, can cause unilateral optic neuritis, or it can also cause the unilateral third nerve palsy because of the compression effect. But bilateral is unlikely, right? So TB is my first differential diagnosis, but tell me anything that comes very close to the diagnosis of tuberculosis, which is very similar to tuberculosis, where you get granulomas, where you get hilar lymph nodes, where you have involvement of the lungs. Yes, that is sarcoidosis. Then what is the difference between sarcoidosis and tuberculosis? The answer here is yes, sarcoidosis. What is the main pathology difference between sarcoidosis and tuberculosis? In tuberculosis, you get caseating granulomas. In sarcoidosis, you get non-caseating granulomas. And that is why whenever you look at the diagnostic criteria for sarcoidosis, it begins with ruling out tuberculosis. First step in the diagnosis of sarcoidosis is rule out tuberculosis, right? After you have ruled out tuberculosis, then we will think of sarcoidosis. Okay, so I will give you the diagnostic points for sarcoidosis just because we are talking about this topic, diagnosis of sarcoidosis in a suspected case, because TB is always a differential diagnosis. Step number 1 will be to rule out TB. Okay. Step number 2, patients with sarcoidosis have serum angiotensin converting enzyme levels elevated. Okay, can anybody tell me why their serum angiotensin converting enzyme levels are elevated? Then step number 3, I need biopsy evidence of non-caseating granulomas of affected organs, or sarcoidosis specific nuclear imaging scans. If I can't do biopsy, then I should have sarcoidosis specific nuclear imaging findings, right? What are those sarcoidosis specific nuclear imaging findings? In your radiology, you study signs like panda sign, lambda sign. These are sarcoidosis specific radiological findings. So to call a patient as having sarcoidosis, first step is I have to rule out tuberculosis. Once TB is ruled out, I will investigate further provided my serum ACE levels are high. And once the ACE levels is high, then I will probably consider going for the biopsy of the affected organ. If biopsy is not feasible, then I have to prove that there are sarcoidosis specific nuclear imaging findings like panda sign and lambda sign, and that completes my diagnosis. Right, because you have granulomas which are formed of epithelioid cells, they can produce ACE, right? You know, the lungs are the ones which produce angiotensin converting enzyme. That is where the angiotensin 1 to 2 conversion happens, right? So from there you can have lot of ACE being secreted, and that we can use for the diagnosis. Now another question that they will ask you is, what is the most commonly affected organ in sarcoidosis, and what is the second most commonly affected organ in sarcoidosis? What is the most commonly affected organ? Obviously lungs, right? Tuberculosis is a differential diagnosis because lungs are the most commonly affected organs. And then what is the second most commonly affected organs? Second most commonly affected organ is the skin. Skin. In skin you get two types of rashes. One is erythema nodosum and the second one is called as lupus pernio. Repeatedly they ask you, where do you get lupus pernio? And most of the time students answer it wrong because the word lupus makes us think that okay, something related to SLE, right? So we can get either erythema nodosum or you can get lupus pernio, which is a rash same like your SLE. It is a malar rash. Here also there may be nasolabial fold sparing, but it is a palpable rash. The SLE rash, the malar rash, butterfly rash is not palpable. Yeah, and the tip of the nose is also usually involved in lupus pernio. Okay. Now there is a next simple straightforward question. There is a CT scan image of a patient who presented with fever, breathlessness, cough with expectoration, right? First thing, when someone presents with fever, cough with expectoration, I'm already thinking about pneumonia or respiratory infections. And here is the HRCT, right? So what do you see here? You can see an opacity, and as you know, within the opacity, you can see the bronchial tree, right? So what do we call this as? This finding where in an opacity, you can see the bronchial tree. What do you call it as? We call it as air bronchogram, right? And presence of air bronchogram is the most specific finding for the pneumonia or lung consolidation. So this we call as air bronchogram. Air bronchogram, and air bronchogram is the most specific radiological finding, for consolidation of the lungs, So what should be our answer here? Obviously it will be option C, consolidation with air bronchogram. Good. Okay, now here is the next question. A patient who ingested 10 tablets of paracetamol, simple, straightforward, I think you should be able to answer this. 10 paracetamol tablets and brought to ED. She has already developed oliguria and liver function test shows deranged values. Which of the following can be used in the management of this condition? What is the drug of choice for paracetamol poisoning? Which is N-acetylcysteine, right? So answer will be N-acetylcysteine. But I have a question. Should we give N-acetylcysteine for all the patients presenting with paracetamol intoxication? See, in India, half of the patients presenting with paracetamol intoxication have taken subtoxic dose. They would have taken a therapeutic dose only. Like I took 3 tablets of 500 milligrams paracetamol, and then I will come saying that I made an attempt to commit suicide because I have taken 3 paracetamol tablets. Should I give N-acetylcysteine for these patients? Right. It is not based on which zone of the liver that is affected. What is the basis for deciding whether we should give N-acetylcysteine or not? Right. So the decision, that can be an MCQ. decision to use NAC is based on patient's serum paracetamol levels plotted on a graph. Based on serum paracetamol levels plotted on a graph. Okay, so what is the name of that graph? That can be an MCQ. So we call that graph as Roumac-Mathieu nomogram. It's called as Roumac-Mathieu nomogram. So that nomogram has a clear-cut line of differentiation. If the paracetamol levels fall below that line, you don't need to give N-acetylcysteine. If it falls above that line, then we give N-acetylcysteine. So the name of that nomogram is Roumac-Mathieu nomogram. The Roumac-Mathieu nomogram can be an image-based question. So just after the class, Google it out. You will see a small table or a graph. Download it and keep it, so that if they give an image-based question asking you to identify where do we use it, you should be able to identify that. Okay. Next, MRI scan of a non-pregnant female who is complaining of galactorrhea revealed a large pituitary tumor who is not willing for surgery. Which of the following is the best drug of treatment? I know you have the diagnosis already. Patient is showing a pituitary tumor. Patient is showing a pituitary tumor and she is having galactorrhea. So in that case, what is your diagnosis? Most likely patient is having prolactinoma, right? Patient is having prolactinoma. Should I operate prolactinoma? What is the treatment of choice for prolactinoma? Is it surgery? Is it surgery? The answer is no. Prolactinomas have excellent response to dopamine agonists, right? So the treatment of choice will be dopamine agonists. They have excellent response to dopamine agonists. They will reduce the secretion of prolactin and the tumor will generally shrink. And the decision whether I should do surgery or give dopamine agonist is not based on the tumor size. All pituitary prolactinomas will be treated with dopamine agonist. Only when they fail to respond, we do think about surgery. Surgery is not the first line of treatment, regardless of the size, whether it is microadenoma or macroadenoma, right? So please make a note of it. This will be the treatment of choice regardless of tumor size. So it's a crime to talk to the patient saying that will you get it operated? No, we shouldn't be thinking of surgery as the first line treatment. Start them on the dopamine agonist. The tumor does not shrink during the follow-up. We expect it to shrink by more than 50%. If it is not shrinking, that is where we think of doing the surgery. So as such, there should be no role of surgery in this patient. And anyway, the answer would be bromocriptine, which is a dopamine agonist, right? Can you name another dopamine agonist that I can use for a patient with prolactinoma? That is cabergoline, right? So can anybody tell me the advantages of cabergoline over bromocriptine? Nowadays, we mostly use cabergoline instead of bromocriptine because bromocriptine is short acting, requires multiple per day dosing, like 3 to 4 times a day we need to give bromocriptine. Cabergoline is long acting, right? Its T-half is more than 60 hours. So I can give it once or twice a week. That way I will be able to achieve a better compliance from the patient, right? The only time today we use bromocriptine is in pregnancy. Mostly because the bromocriptine's safety is well proven. Over last 40 years, many trials, we know that bromocriptine is safe. That also doesn't mean that cabergoline is not safe. It may be safe, but we have more data for the proof of safety of bromocriptine, and that is why we continue to prefer it in pregnancy. It is preferred in pregnancy. And cabergoline is generally the preferred choice for all other patients. It is the preferred choice for all other patients. Good. Okay. The next question. The jugular venous pressure finding in patient presenting with an irregular pulse of 120 per minute and a pulse deficit of 20 is suggestive of. So from here, make a diagnosis. First thing they are telling is that there is irregular pulse. And they have also mentioned that there is pulse deficit of 20. So first thing I want you to understand is what is pulse deficit. What is pulse deficit? Right, all of you gave, most of you gave the right answer. What is pulse deficit? What is pulse deficit? Yes, irregular pulse. First thing that comes to our mind is atrial fibrillation. But please remember, you can have other conditions where you can have irregular pulse. It is not only the atrial fibrillation. If you have multifocal atrial tachycardia, you can have irregular pulse. There are other conditions. Right? So here, instead of giving you the ECG, examiner is giving you an indirect hint for the diagnosis. Atrial fibrillation is the most common cause for irregular pulse. I agree beyond any doubt. It is not exactly atrial rate versus ventricular rate. It is the difference between heart rate and pulse rate. Heart rate we auscultate, right? By auscultation, how much heart rate we calculated by auscultation. The difference between systolic and diastolic BP, we call it as pulse pressure. Pulse pressure is different from pulse deficit. See, I auscultate, I get a heart rate. Let me say that is 120. I feel the pulse, I get the pulse rate. What is the difference between the auscultatory heart rate and palpatory pulse rate? That is our pulse deficit. Pulse rate is measured by palpation of the pulse. Normally, this should be normal pulse deficit should be less than 10 per minute. 10 per minute, right? And the most common cause for pulse deficit more than 10 per minute is atrial fibrillation. Atrial fibrillation. So that is the clue from the examiner's side saying that this irregular pulse, which can be because of 3-4 arrhythmias, this is clearly atrial fibrillation because the pulse deficit is more than 10. Here they have mentioned that it is 20. So diagnosis, as you all guessed, is right. It is atrial fibrillation. And in atrial fibrillation, what is the JVP abnormality we will get? Atria is not contracting. When it contracts, it produces A wave. If it is not contracting, merely shaking, it won't produce A wave. So what do we get? We will get absent A waves. And that would be the answer. So most of you got it right. Okay. So one more question. A chronic liver disease patient presented with abdominal distension, jaundice and pruritus. Ascitic fluid analysis revealed neutrophil count of more than 650 per cubic millimeter. What is the most likely diagnosis? Right. So please remember, ascites can lead to various complications, and one of the known complications of ascites is spontaneous bacterial peritonitis, which is a life-threatening complication. How do we diagnose it? The diagnosis will be based on the ascitic fluid neutrophil count, right? When the neutrophil count is more than ascitic fluid PMN count more than 250 per cubic millimeter, we will make the diagnosis as spontaneous bacterial peritonitis. And here they have clearly mentioned that it is 650, so the diagnosis becomes spontaneous bacterial peritonitis. Another MCQ they will ask you is, what is the most common organism responsible for spontaneous bacterial peritonitis? Most common organism. Yes, the drug of choice is ceftriaxone. What is the most common organism? See, the tubercular ascites would have presented with lymphocyte predominance in the ascitic fluid. And then again, the ascitic fluid ADA level would have been high. So they would have mentioned all of that. And clearly they have mentioned that it is a case of CLD. A patient of CLD is more prone to develop the spontaneous bacterial peritonitis rather than tuberculosis. It is happening in the backdrop of an existing CLD with portal hypertension. Right. So how organisms reach the ascitic fluid? Because of the transmigration from your intestines. So what organisms we have in intestines? Right, like mainly the E. coli, right? Most common organisms are intestinal bacteria, which includes E. coli among the most common ones. And ceftriaxone works well for the E. coli, and that is why the drug of choice is ceftriaxone. Okay, now a patient presented with yellowish discoloration of skin and sclera. On evaluation, bilirubin and alkaline phosphatase levels are elevated. Remaining liver enzymes are in normal range. What is the likely diagnosis? See, they have already told bilirubin is elevated. That means there is jaundice, and alk phos is elevated. So what is it pointing towards? SM, I will definitely do that. So where do we get elevated alk phos? So please remember, this is a very vague question, not a very ideal question that I would have framed if I was the examiner. But yes, examiner is trying to push you towards the presence of obstruction, right? So whenever we say elevated alk phos, it is suggestive of obstruction. So that's why I would choose obstructive jaundice. But I will give you a small homework for better differentiation or better approach to LFT. There is something called as R value. So soon after this class, I want you to spend 1 or 2 minutes understanding the R value to understand whether the jaundice is because of obstruction or whether it is because of the dysfunction of the liver cells. Hepatocellular jaundice versus obstructive jaundice. How to differentiate that based on the R value. Okay, so guys, the time is up for today. We have a few more questions. I think we have covered around 50% of the questions from last 3 years. There will be another 50% questions. I will do a second session covering the rest of the questions, which you will also get on the PDF, so that before we get going with the live next time, you would have already solved these questions. It will make it easy for both of us to understand. Okay, see, GGT is again a value which goes hand in hand with alkaline phosphatase. Okay, generally alk phos elevated, GGT will also be elevated. And apart from that, alcohol can also induce GGT. So in today's practice, if I have only GGT elevated with alk phos normal, we can think of alcohol induced elevation. If both are elevated, we will always think of obstruction. Okay, so guys, that's it for today. I will share the details of the next session once the team gives me the free dates, and we will cover the remaining questions. I will leave the remaining questions in the PDF so that you can solve them, and when you come next time, you will have a fair idea what kind of questions to expect and what are the important topics. All the best guys, and study well. Important things, I will be doing one more session on scores, because 2 questions come in NEET PG on scores. There are only some 7-8 scores. So if you spend half an hour, 2 marks are assured. Similarly, we will do a 20-minute session on the ABG, from which every exam we get 1 question. And nowadays the level of questions is increasing from simple diagnosis to compensation, fully compensated, partially compensated, non-compensated. So we will cover all the discussion in another individual session. So for now, I am signing off guys. All the best and study well. Thank you all. Thank you. The PDF will be shared on the PW Meded Telegram channel. Thank you guys. Thank you. Thank you all.